My name is Peggy Imonyovu, and I work for PharmAccess Foundation. PharmAccess is very happy to be collaborating with her pharma to get this webinar across to you. Before we start, I'd like to read out some housekeeping rules. Please ask your questions in the Q&A panel. And one of our team members would respond to you. And because we have participants from all across Nigeria and some even outside Nigeria, we may have a bit of connectivity issues, so please bear with us, but we'll do our best to see that this goes as smoothly as possible. Now, I'll be handing over to Dr. Abiola Idowu, who is the Executive Secretary of her pharma and the host of this webinar. Over to you, Dr. Idowu.
Pandemic is a public health crisis, and its effects are far-reaching. And we also know that training of healthcare workers is a crucial step to controlling the spread of the disease and managing the new cases. So we're actually very happy to collaborate with PharmAccess because the webinar is going to empower us to safeguard the lives of our patients. And I'm sure that by the end of the webinar, would have been trained and have a better understanding of the virus. Thank you very much.
Thank you, Dr. Idowu. So for today's webinar, we have two speakers. The first is Professor Tobias, who is a molecular biologist and a public health specialist and a director research of PharmAccess Group and the Joop Lange Institute in Amsterdam. Tobias stimulates multiple disciplinary operational research along the agenda of PharmAccess with complementary inputs from the Institute. His research is mostly in the areas of healthcare quality improvement, healthcare financing, diagnostics, and the use of innovative mobile health technology. Tobias holds a chair at the Institute of Amsterdam and leads at the Department of Global Health and Amsterdam Institute. These are a team of scientists, PhD and master students. In his position as principal investigator at the Department of Global Health of the Institute, Tobias is developing the so-called connected diagnostics technology for improved quality and financing of healthcare delivery in Africa. Other focus of his work are on HIV drug resistance in Africa, and in that respect, he serves as co-chair in the WHO Global HIV Drug Resistance Network. Tobias is an AIGHD research coordinator of a large-scale HIV test and treat program in Tanzania. He has published over 225 articles in peer-reviewed journals and is serving in the board of Model DX and of Health Inc. Incubator, both in Amsterdam. Our second presenter is Dr. Folarin Opawoye, who is a physician with specialization in infectious disease. He obtained his medical degree from the University of Folarin Teaching Hospital, thereafter proceeded for an advanced training in emergency response in 2014 and has been involved in several other outbreaks since that time. His research interests include antimicrobial stewardship, infection prevention and control, and outbreak investigations. Dr. Opawoye currently serves as an infectious disease physician in Lagos University Teaching Hospital and the Infection Prevention and Control Team Lead for Lagos COVID-19 Emergency Operations Center. He's also a member of the Nigerian Infectious Diseases Society, where he currently serves as the PRO. Beyond his medical profession, Dr. Opawoye is an expert compere and an award-winning public speaker. So I'll hand over now to Tobias to begin his presentation. So over to you, Tobias.
Thank you very much. It's a great pleasure to be here again. In terms of questions, please ask your questions through the Q&A panel. And yeah, there might be some connectivity issues. I do hope we'll get there. We are now at 151 participants, so that is a big congratulations. And here are the names of the speakers, and I will start my presentation now. Here are the different, our host, our moderator, and the two speakers once again. All right, I will tell you something about the virus. I'm a biologist, I'm not a medical doctor. So I'll give you some more virological, immunological, and epidemiological information that is from the latest literature and from the latest findings of the last, let's say, 1.5 to 2 months in total. So first of all, we're talking here about the virus. SARS-CoV-2, the official name, is a quite simple organism. It's a so-called RNA virus. It has a nucleus of RNA, genetic information. It is around 30,000 base pairs long, or bases in fact, which means it's 3 times bigger than HIV, 3 times larger. It has 14 so-called open reading frames, it means genes, and it has 27 proteins. So it is a very simple organism. If you look at the sequence of the genetic material, it is approximately 80% similar to SARS, which was the epidemic of 2003. I'll come back to that. And it is 96% similar to viruses from bats. So it is for sure that this virus originated from bats and probably went to human beings through an in-between host. And I'll come back to that. It's only 50% identical to MERS. MERS is another important coronavirus infection. And we can see here the genomes, the genetic materials of SARS-CoV-2, the current virus, compared to SARS-CoV-1 or SARS-CoV, the epidemic of 2003, and compared to MERS. And basically, you can see that those 3 viruses look quite alike. If we look at coronaviruses in general and the zoonoses that took place over the last years with human beings, then basically there are 2 different types of zoonoses, the old ones and the new ones. The old ones probably are circulating amongst mankind already for 100 years or maybe 200 years. These are coronaviruses with quite esoteric names, 229E, NL63, and so on. And these viruses have lived with human beings for a long time, and therefore we don't really get sick of them any longer. They just give light flu kind of symptoms. You see them often in small children. They're transient, they don't cause any serious disease. And they are both of the alpha and of the beta family. In fact, there are 4 families of coronaviruses, alpha, beta, gamma, and delta, but only the alphas and the betas can live in human beings. So that's why they're shown here. However, there are also the new zoonoses, which are the new infections of SARS-CoV-1 in 2003, MERS in 2012, and SARS-CoV-2 in 2019, the current epidemic. So what we see is that in the last 20 years, less than 20 years, there were 3 major zoonoses of coronaviruses. And whenever there is a new zoonosis, this always creates a lot of problems and disease, because the equilibrium between the virus and the host, in this case the human being, have not been found yet. The old zoonoses probably have also caused a lot of troubles in the past, maybe 150 years ago, but we don't see those effects any longer because now the viruses have adapted to the new living conditions in human beings. Here we see the transmission from a camel to a human being of MERS as an example. I'll come back to that. A big question that's often asked to me is about how stable is the virus, how strong is it, and how careful should we be with cleaning and with sterilization. There are a couple of papers here, you can look them up. This PowerPoint is available for everybody. It can be shared later on, so you can click on the links here in the Lancet and in the New England Journal. Basically, the virus was tested for viability, which means that it still is alive after a while, on different kind of surfaces. And you can see that even on plastic, the virus can survive for almost 72 hours. On stainless steel for 48 hours. On copper and on cardboard for 8 hours. In other words, the virus is quite stable. And of course, it will be damaged when it is for such a long time on such a surface. But it is still possible from dried up plastic that was in touch with drops from a patient who was positive, that 72 hours later, you can still isolate viable viruses from it. In other words, there is surface transmission through surfaces, but we don't know how much. The most important route of transmission, of course, is by sneezing, by shaking hands, by touching your nose, your eyes, your mouth, for sure. But surfaces do play a certain role. Well, talking about transmission, I said already, the virus's host are bats, and there are many different coronaviruses in bats. One of them went through camels to human beings, which was MERS, approximately 10 years ago. And the other one went through civet cats to human beings. That was SARS-1. And probably SARS-2 went through the pangolin, and I'll come back to that. And as soon as the virus is in a human being, then of course human beings can infect each other, and they get in the hospital, they could infect nurses, it could go back in nosocomial infections. In other words, now the virus has moved into a human-to-human transmission situation. Here is the pangolin, the in-between host for SARS-2. We're not going to go into the details here, but I just wanted to show you two interesting things that happened, two mutations that make SARS-2 quite dangerous. And if we look at SARS-2, the genetic information, you can see it on the top of this page, the blue line here, and it's 30,000 long. You can see the spike protein here, which is encoded. And the spike protein is the protein on the outside of the virus, which makes it look like a crown, a corona crown. Well, in that spike protein, if you enlarge that, you can see there are two mutations. One is in the receptor binding domain, and the other one is in the polybasic cleavage site. And those two mutations, the one in the receptor binding domain, create a much higher affinity with the receptor ECA2 than normal. In other words, SARS-2 has an increased affinity with the receptor ECA2 as compared to SARS-1 or to MERS. And the second mutation is the polybasic cleavage site, which basically means that the virus has enhanced cell fusion characteristics, which means it can easier fuse with the cell membranes of cells and enter cells. In other words, the virus has a couple of peculiar traits that make it more infectious. I'll come back to that. Here we see a typical example of transmission dynamics of the virus, an index patient number 1 and patients 2, 3, 5, 4, 5, 6 who have been infected by patient 1. The characteristic period here is that there is an asymptomatic period in light gray for every patient before symptoms show up. Symptoms are in the orange. And even before viral load is demonstrated by PCR in pink. In other words, the virus has 1 to 2 weeks asymptomatic time periods before there are clinical symptoms. But it is already there, which means that transmission of viruses can take place before people actually get infected, symptomatic, sorry. That's important. So if we add this all up and we talk about the virus and its transmission efficiency, then once again, first of all, there are those specific mutations that increase its binding to the receptor and the cell fusion. I've shown that to you. Then there are high viral loads. The virus has clearly pretty high viral loads, particularly in week 2 after clinical symptoms. Then there is prolonged shedding of the virus. In other words, even in the asymptomatic period, like I showed to you, the virus is already shedded by people and can be infectious. And even after finishing clinical symptoms, the virus can still be infectious. And finally, important, the tropism of the virus is also very specific for the nose. So the entry point of the virus is usually the nose, and it is specifically infecting 2 different cells, the nasal secretory cells and the ciliated cells. You can see them here, the ciliated cells and the secretory cells. These are the 2 cells that have a very high expression of ECA2, which is the receptor for the virus. And that's the way the virus starts to multiply, first in the nose. And by breathing, with every breath, you breathe in more of those multiplied viruses into your lungs, which is the second stage of amplification for the virus. In other words, it's a 2-step rocket approach. First your nose, then your lungs. Another important point is that the virus can also be detected in feces, in stool of human beings. Here we can see an important study in British Medical Journal. In fact, the viral loads in stool were pretty high, even higher than in respiratory tissues or even in serum or blood. The contribution of stool to the transmission of the virus on the population level is unknown. Probably it's quite low, but it cannot be excluded. There is active replication going on of the virus, not only in the lungs, but also in the gastrointestinal tract. And I will come back later, particularly also in certain organs. So the role of stool is not completely elucidated as yet. Some characteristics in the clinical arena. First, symptoms. These are studies, first of all, done in China and later on in New England, published in New England Medical Journal. Obviously, fever in the Chinese situation was the most common symptom, followed by cough, myalgia, headache, and diarrhea. But over time, on the left-hand side of this slide, many more symptoms have been recorded, like also loss of taste and loss of smell, confusion, diarrhea, sore throats, rhinorrhea. In other words, it's a mixture of symptoms that can be seen in different parts of the body. But of course, symptoms are not enough. You need an actual test to be sure that the virus is there. And I will talk a bit about those tests later on. Just to show you the dynamics, this is the a study done in the New England Journal on the first case of coronaviruses in the United States. Well, today there is 1 million people officially infected in the United States and confirmed by viral load testing. This was the first patient. Only, what is it, 3.5 months ago, January 15. The person came in from China, and we can see here the symptoms developing in that person. Cough started pretty soon. Rhinorrhea started much later. Fatigue started soon. Nausea came up, went down, came up a bit. And so you see those symptoms are on and off, present and absent in a patient. And this is different per patient. If we look at the dynamics of infection, and this is a picture from the WHO and also in clinical infectious disease, then basically from day 0 onwards, there are in the beginning no symptoms. On the blue line, you can see that symptoms are only setting in, let's say, 5, 6, 7 days after infection, and then they go up and they become quite serious at day 14, 2 weeks after infection. During that, or just before that period, also the IgM, the immune response against the virus, starts to build up, but that's a transient immune response that disappears pretty soon on day 21, and then the IgG response is following later and stays on much longer. In other words, there are IgM and IgG antibodies formed against the virus. And I'll show that to you later also in my presentation part about diagnostics. We've just reached 200 listeners. I'm very, very proud. This picture shows us a bit that the disease, in fact, is a phased disease, and there are stages in it. And in the first stage of the disease, it is mostly the virus. It's the virus that is going in the nose, then moving to the lungs, as I explained to you. It's replicating at high speed, and it creates all kinds of damages to the epithelia of the lungs because of cytotoxic T cells that kill the virus. And the immune response against the virus is coming up a bit later. And the virus seems to dysregulate the immune response in an unknown fashion. The CD4 T cells, which are the most important component of the immune system, and which, by the way, are the direct site of attack by HIV. Again, in this particular disease, the CD4 cells, and particularly the regulator cells, get confused. And they start to give signals to the B cells and the cytotoxic T cell part of the immune system that continue and don't stop. In other words, the cytotoxic T cells keep on producing cytokines. We call that the cytokine storm. So there's lots of cytokines produced. And the T cells keep on killing other cells. And they also kill uninfected cells. In other words, you get an additional damage created by the host immune response, which is even far worse than the damage in the first phase against the virus. So a lot of the clinical symptoms are in fact related to the immune response of the host. 2 other important slides which I would like to share, very recent information there is a lot of kidney damage going on in SARS-CoV-2 infected patients. Here we can see also electron microscopic pictures where the viruses are clearly there. This is done on autopsies of people. There is clear acute kidney injury in up to 30% of the cases, and the particles are obviously there. There's proteinuria, hematuria, and there's often dialysis needed as well. And also another very important recent finding is blood clotting. So the virus confuses the immune system, as I said before. It also confuses the complement system of the immune system. In other words, complement keeps on reacting in a strange way. It creates a lot of clotting, which can lead to strokes. It can lead to thrombosis, and also strokes at a relatively young age. And there's New England papers on that, which you can look up all the details. What are we doing against that virus in terms of therapeutics? Basically, there are two big angles. There is the antivirals and there is the immunomodulators. The antivirals mostly for the first stage of the disease, the immunomodulators for the second stage of the disease. Obviously, for the antivirals, we first recycle drugs that are already there. That saves time, the drugs are cheaper, and the toxicity work has already been done on those drugs. So we see, for example, recycling of the drug lopinavir/ritonavir, which is an HIV drug, recycling of hydroxychloroquine, which is a malaria drug, recycling of remdesivir, which is an Ebola drug, favipiravir, which is an influenza drug, ivermectin, a parasite drug. These are all clinical trials ongoing on recycled drugs. We know now that there are almost 500 clinical trials ongoing. Let me give you one example of a disappointing clinical trial, which is the hydroxychloroquine trial, which just came out, done in the United States on 368 hospitalized patients. Well, the message in short is it did not work. The risk of death in the hydroxychloroquine treated group was 2.6 times higher than in the control group. Well, that's certainly what you don't want. In other words, this one is out. If we look at fatality rates, I don't think I have to tell you much in detail about that, but basically the disease is hardly causing any fatalities until the age of 50 in Europe and in the United States and in China. And then it becomes more important, of course, in older age groups in terms of fatality. Often people also ask, what is RO, the basic reproduction number of the virus? It basically means if the epidemic is just going its own way without any interference by human beings, how many people get on the average infected by one single person? Well, for influenza, it's around 2. For SARS-CoV-2, it's around 2.2, 2.3. For measles, by the way, it is around 12 to 18. So that's an extremely infectious virus, which can infect 12 to 18 other people by one particular patient. If you compare COVID, and in this case COVID-19, with other diseases, then if you take the basic reproduction number on the x-axis, I just explained to you, COVID is in the order of 2.2, 2.3. And if you take on the y-axis the case fatality rate, then you see that COVID is basically in the not too dangerous zone. Ebola obviously is much more fatal, 50% case fatality rate. MERS also was a much more fatal disease, 33% fatality rate. COVID has an average of 3.5% overall fatality rate in China and in Europe and the United States. So it gives you a bit of an idea. And also compared to the big Spanish flu of 1918 that killed millions of people in Europe, it is in the same kind of range in terms of RO and in terms of case fatality. I promised to tell you something about diagnostics. Because this is part of the story. Well, if we see the epidemic as an iceberg, then it is obvious that if you do a lot of testing, like on the left-hand side of the slide, much more of the iceberg is above sea level. You can see it. If you do a little bit of testing, the iceberg is underwater. So that means it has an enormous consequence on the figures of your epidemic in the country. On the left, we see Germany as an example country with a lot of testing, and therefore the reported death rate and severe disease rate was only 0.25%. While in the United Kingdom, the iceberg was mostly underwater with little testing, we get a 4% rate, which is 12 times higher than in Germany. In other words, we have to be careful. We always have to put our data in the perspective of the total number of tests done in a particular country. Well, for countries like Ghana, I know 115,000 people have been tested. In Nigeria, the test rates are very low. I think at the moment they're in the order of 12,000, or what I saw. Well, the number of identified cases are in the range of 2,000. So we have to be careful with those statistics, and I'll come back to that in the discussion. Basically, in terms of lab tests, it is a mess. Yeah, that's the general message. There are more than 350 different test developers who are submitting documents to FDA and who are trying to get approval. Up to now, FDA has issued 42 individual emergency use authorizations, as they call them. That's not really an FDA approval, but it is at least an authorization to use this kit in emergency circumstances. There is an organization in Geneva named FIND, and I can advise you to go to their site, which you can see on top here, that is currently evaluating all those different tests and gives those results on their website. The website is on the left bottom here. You can push the button and you will find which tests have been evaluated, which ones are allowed, which ones are not, what is their sensitivity and specificity. But just to summarize this for you, just in 1 or 2 minutes, the golden standard, obviously, for COVID testing is the virus. And usually that's done by big PCR machines like the Abbott's or the Roche machines or the Thermo Fishers or the Becton & Dickinson's. These are big machines that not always are possible in any laboratory circumstance. These machines are all good and they all give reliable results, but of course they are very expensive, and the tests and the test kits are expensive as well. A more point-of-care solution are either the Cepheid on the right-hand side Gene Expert machine, or on the left-hand side the Abbott ID Now COVID-19 test system. Both are giving results in much less time, 15 to 45 minutes. The prices of those machines are between, let's say, $5,000 and $18,000 US. But of course, the tests are done one by one or in small modular batches. So it goes much slower. Important to know also that the Cepheid tests have the advantage that the Gene Expert machine has already been distributed in many places in many countries. I'm sure there are lots of Gene Expert machines in Nigeria as well, although far majority will be in the public sector. And those machines can also do HIV testing, hepatitis B and C. So that is an advantage as compared to the ID Now COVID-19 test of Abbott, which can only do SARS-CoV-19 at the moment. Then, of course, there are antigen tests, which an antigen is, of course, also the virus itself, but it is a protein. These are rapid test kits that are currently none of them approved. But in principle, it is a test, of course, that would be very nice because it goes for the virus and it is rapid and it should be affordable. But they're still under evaluation and none of them has been approved, neither in European nor in American guidelines. In terms of antibody tests, that's my 1 or 2 last slides, there are many of those tests floating around and flooding the markets, and we have to be careful there because there is a lot of non-good tests going around, particularly tests that have been donated. At the moment with FDA, there are only 4 serological tests that have been approved. 2 of them are really rapid diagnostic tests, which is the Celex and the Cambio tests. I'll show you them here. The Celex is on the right-hand side, which is truly a rapid diagnostic test on a test strip and a test for immunoglobulin G and M. And then there is the Cambio strip, which needs a small reader, a small machine, which is not too expensive. These are the only 2 immunoglobulin tests that have been now FDA approved. The other 2 tests on this list need an ELISA machine or other luminescence devices. So again, they are more expensive. So basically, the last slide I wanted to show you is about sample handling. The best samples for testing for SARS-CoV-2 are taken from deep into the lungs, which would be a bronchoalveolar lavage, which is not possible in real life. Second best maybe is sputum, but often that is not possible. So in practice, most of the time people take nasopharyngeal swabs or oral pharyngeal swabs, and that can be done by self-sampling. Nasopharyngeal swabs is done by healthcare staff, but there are some risks. or people start to sneeze, and that's not nice for the nurse who's taking the sample. So there are some risks involved. The alternative is that the patient, him or herself, takes the swab from the oral cavity, oral pharyngeal cavity, and there are even now already data that saliva is good enough for doing the test. And this is basically my presentation, and I thank you for your attention. I think we go straight to the next presentation, or would there first be some questions? Moderators?
We have a number of questions. Thank you for your presentation. So for time's sake, I'll just pick a few because there are quite a number here. So this person is asking that at the very slow test rate in Nigeria for a disease with such contagiousness, where
Yes.
every second counts, how dangerous are the emerging days in a country of about 200 million people? What's your view on this?
Well, obviously, it is extremely important to test people as quickly as possible, because if you don't know status of people, then you will have to stick to draconian measures like taking place now. The whole, let's say, lockdown situation has an incredible economic impact. It is socially often not possible to do, and preferably the alternative, of course, is to go for massive testing of people, and then, of course, for the positive, isolation at home or in isolation hotels, even like we do in Kenya, or in isolation tents or otherwise. And so test, track and trace and isolate would be a much economically more sensible approach for a country. It's like Singapore or Taiwan. That's how they did it. And it is a pity in a way, but that's my personal opinion. It's a pity that in many African situations, they copy paste what is happening in Europe, which is not good for them. Test and trace and isolate. That would be the best way.
Thank you, Tobias. So that's another question. And this person says, you mentioned acute kidney diseases and formation of blood clots. Are these the long-term side effects that anyone who recovers from will suffer?
No, that could be, but these are also effects that happen, for example, with patients who are in the emergency rooms and who are hospitalized. These are the new data that are coming up that people who are in coma, they suddenly get a stroke, or they have severe kidney problems, and they need a dialysis or dialysis, I think you say in English. So it also happens during the disease, not only afterwards.
All right, thanks. So there's another one here. And this person wants to know what your comments are on the test methods purported by Senegalese scientists, and if they are useful for detecting the coronavirus.
Can you repeat that question? Senegalese scientists and diagnostics, but what was the question?
Yeah, so
Hello?
hello?
Yep, you're back again.
Okay, thank you. So this person wants your comments on the test method purported by Senegalese scientists as being useful for detecting coronavirus.
You know, everywhere at the moment in Africa, home-based PCRs in big laboratories are being developed. And I think that's good, and they should be used, because any testing capacity that is there should be used for the virus. So as long as you go for a PCR-based nucleic acid approach in good reference laboratories, that is fine. The only thing you have to be careful with, particularly, are serological tests and rapid diagnostic tests, because the far majority of them, you know, give 30, 40, 50% incorrect results.
All right, thank you. So one last question before we move to the other speaker. Comparing the PCR machine and gene expert testing, what is the sensitivity and specificity? English fails me. Yeah,
good point. Well, it's on the bottom of this slide. The lower limit of detection with Cepheid is 250 copies per milliliter. That is not as sensitive as the big machines, as these ones, but it is very close to it. These big machines are in the order of 40, 50 copies per milliliter. It is a little bit less, 250 copies, but it's very acceptable. So in a way, at the moment, in my personal view, the Cepheid machines are the most appropriate point of care options at this stage. Also because these machines have proven their value because they're in Africa already for years. So there is maintenance systems in place, and there's experience with those machines. Not yet with the Abbott ID Now machines.
All right, thank you, Tobias. So we'll move over to the next speaker. Please keep your questions coming. We would attend to them after all of this, but please ask your questions in the Q&A panel. I've noticed a lot of questions are coming via chat. So now over to you, Dr. Folarin. Thank you.
Hello, can you hear me?
Yes, we can hear you. Please go ahead. Okay,
great. Thank you very much. Okay, so thank you very much, Professor Tobias. I mean, I've taken a lot of notes. It's been, I mean, job that you know, an eye opener into a lot about the virus, how it's transmitted, the some of the dynamics, and also and all that. It's really been an eye opener, and I believe that we're going to ride on the shoulders that you have given us to move into the next part of the lecture. Next slide, please. The next slide. So, okay, thank you very much. So this is the outline of what we're going to be doing. We're going to be talking about improving infection prevention and control practices. Now, it's important to note that there is no disease that has ravaged the healthcare workers like COVID-19. We've dealt with a lot of infectious diseases, starting from things like HIV, like hepatitis B, hepatitis C, and even the dreaded Ebola and Lassa fever, which that's the outline. You can move on to the next slide, sir. Which have all been very, have caused quite a few deaths, I mean, amongst doctors, you know, but nothing like this coronavirus. We've had hundreds of doctors die all over the world, and it's been a particular challenge. About 1,000 doctors have been infected. Thousands of doctors have been infected all around the world. Hundreds have died, and you know, in the United States, for example, where we have a bit more complete data, between February 12 and April 9, about 9,282 healthcare workers were infected. And this represented 19% of the total number of infections as at that time. Now, 90% of those healthcare workers were not hospitalized, though severe outcomes were seen in all age groups, with 27 deaths recorded, but most of the deaths were occurring above the age of 65, which again, like Professor Tobias said, by the time you go up from the age of 50, the worst outcomes increase. 92% of them were asymptomatic because the CDC don't really test people who are, 92% of them were asymptomatic, 8% were symptomatic, and the CDC acknowledged that the data is actually incomplete, you know, because of several reasons. Now, this is just a table looking at the age group of these healthcare workers. And again, we can see that greater than 65, 10 of them died out of the 97 of them that were admitted, and 35 of them were actually in ICU. And they were, again, the largest age group that were associated with severe outcomes in this disease. And this is very important when we are looking at IPC measures. Next slide. Okay, so this is a pie chart. Now, the difficulty in looking at healthcare worker infections is that for some of them, you're not really sure where exactly they got it from, especially when you have sustained community transmission, which is like what we are having here already in Nigeria, in some cities, especially like Lagos, like Kano, and probably even the capital in Abuja. We know that there's community transmission, and you know, so for them, you are not sure whether the healthcare worker, the nurse, the doctor, whether they actually got it in the hospital or they got it from the house or from the community. So we can see here, 55% of them got it from the hospital alone. That was what they thought. Again, you can't be too sure. but that was where they knew they had a contact with a suspected or confirmed case. 37% of them from the household only, 13% of them from the community, and 5% of them just couldn't say. They had multiple contacts, multiple exposures everywhere. Next slide, please. So in Lagos, as at 27th of April, we had more than 128 healthcare workers who had been infected. This data keeps going up, every day. We're looking at from the 7th of March, which was when the Lagos epidemic started, till now. Till now, probably the numbers will actually be closer to 200. Interestingly, about more than 80% of them are actually asymptomatic. They were just picked up from when they were in contact with confirmed cases. And it's also interesting to note, and very important, that most are from the private hospitals. And this is of especial concern to us and to most people. There have been a few, there have been some at the public hospitals, some have occurred even at the isolation facilities, but most of these healthcare workers coming from private hospitals, with some hospitals recording close to 30 cases following a single exposure. It also bears with what Professor Tobias said about the infectivity of the virus, and then some mistakes were actually made at some of these facilities. And that is some of the reasons why we had to talk about this, to look at how we can try to mitigate some of these things. We've had one death from Lagos. We've had about 3 doctors have died in Nigeria as a whole. And I think a nurse has died too, but in Lagos we've had only 1 death, and obstetric and gynecology consultant, may so rest in peace. Next slide, please. So it's important to look at the levels of infection control. And this is very crucial, because in infection control, you have to protect yourself, protect your colleagues, you have to protect other patients, and you're also protecting the community. There's an interlink, there's a web between all these levels, because when a lot of people are focused on protecting themselves, and they leave out these other things, and then they actually still get infected because they were not watching out for their colleagues, they were not looking at the community, they were not looking at other patients. So it's very important to note this, all these different levels, that while you are trying to protect yourself, don't forget that you have to look at the environment, look at the community, you have to look at your other colleagues and make sure that they are all included in these levels of control and prevention. Otherwise, you eventually, your whole control systems will fail. Next slide. Now, very crucial for us, because a lot of times when you talk about IPC in Nigeria especially, it's not a very well developed practice. I always say that many of us as clinicians, I'm a clinician, infectious diseases, and many of us for those who work in the hospitals, have taken care of TB patients, patients with tuberculosis at one time or the other, and many of us don't even use surgical face masks, not to talk of N95s for this people. So we don't do barrier nursing when we're giving drugs like vancomycin, meropenem, and all that. We don't do screening for antibacterial-associated diarrhea. So there's just so many things we are not doing. You understand? And then when this kind of issues come, it becomes an emergency. Then we try to get processes in place because all of a sudden healthcare workers are getting seriously infected. But the problem is, when you talk about IPC, people insist, and all people talk about is PPE, that's the personal protective equipment. And as you can see, it's an inverted pyramid. The PPE is actually the least important component of IPC, because you can get your PPEs, and if you don't get it right, you're going to miss everything. The administrative controls are the most crucial. You can see that they take the most features in a triangle, followed by engineering controls, and least of all, the PPE. Because if you don't have these controls in place and you are relying on your PPE, then you're actually in trouble, because there are a lot of variables with the PPE. And I always tell this to people we lecture, that when we through our training programs, that N95 is just 95, it's not 100. And that 5% could actually be deadly. So you're not relying on that N95 mask you're wearing. You are relying on so many things. so that your PPE is actually your last line of defense. It's very important to realize this because we focus on PPE and forget so many other important things. And at the end of the day, you know, everything comes to naught. Next slide. So the most important thing, next slide, sir, is the administrative controls. And I mean, we're talking about providing training and retraining for healthcare workers, which is very crucial. And this is one of the things that PharmAccess with a pharma is trying to do, you know, create this international body of experts to try to talk about some of these very crucial things. And this training, we have to really understand how this virus is transmitted, which again, Professor Tobias has done a very great job with, so that we can know actually what we need. One of the challenges we face in Nigeria is that people trying to use the controls for Ebola to take care of COVID. And then it creates a lot of challenges, and it creates a lot of wastage in the system, and it's totally unnecessary. So this training is important, retraining is important for those that have been trained. All of us have different rates of assimilation, and it's very important to do these things over and over again. So this is not a one-off. I hope PharmAccess will organize many, many more training sessions. It's very crucial. All staff need to be trained. You cannot, the mistake some hospitals make when they are training is to send only the top management. And then you are not training the cleaners, you are not training the porters, you are not training the nurse assistants. And then these people are going to break the chain of infection. They're going to be the ones that are going to eventually destroy the entire system. So all staff need to be trained, starting from the security of the hospital, the security, the gatesmen. We've had some of the cases we had in Lagos, even the security staff were infected. So it's very important to note these things. And then you have to monitor compliance with standard precautions and provide mechanisms for improvement. Training is not enough. There has to be a monitoring system. There has to be a checklist where you look at the things that you've trained them on, and you have to look at how much they are, look at the gaps in the training, and look at how you're going to address them. You have to establish a surveillance process for acute respiratory infections among healthcare workers. Now, this is very crucial because a lot of times the focus is on the patient, and we forget the enemy within. From the experience we had in Lagos, Nigeria, quite a lot of healthcare workers got infected from other doctors. So what happens is that the doctor goes out, gets infected, and then transmits the infection to another doctor, and then it becomes a boomerang like that. You know, it becomes a real messy situation. So even doctors must be triaged. Many of our hospitals that have triaging and screening points, we have it for the patients, and then we ignore the doctor, forgetting that the doctor or the healthcare worker, the nurse, anybody can also be a patient. So that's a big challenge. We had a particular hospital where they had very strong protocols in place. However, they neglected to screen their own staff, and it was one of their staff that eventually broke through the process because he was not screened, got into the hospital, and at the end of the day, they had massive infection there. So these are things to really note, and note that it's very, very important. All system, you must have a surveillance system. Temperature checks must be for everybody that is entering the hospital. Symptom check for everybody entering the hospital. It's very important to use job aids and visual reminders. These are going to be pasted at different strategic locations in the hospital, so that it serves to help to boost your memory and it serves to remind you of the work you have to do. Also, adequate staff to patient ratio is very important. Remember that working with some of these patients can be very tasky, and when you're fatigued, then you make mistakes. So it's very important to ensure that in all our facilities, we have an adequate staff to patient ratio, especially in these challenging times. Next slide, sir. So those are pictures taken from various trainings that we do, in various facilities, public, private. We try as much as possible when we can to do maintain social distance even in our trainings, and we try to train with all the modes of PPE available, because sometimes you cannot dictate which kind of PPE would be found or will be produced or supplied. So we try to tell people this is what you need. However, if you have this, it's also fine. And then we try to do that, with different adaptations that we have used for our own environment. Yeah, so the first picture there at the corner, at the left-hand corner, that's a Veronica bucket, which is a modification so that it can ease hand washing, because many of our facilities do not even have easy and sustained access to running water. So this is very important. The other one was a training with in one of the teaching hospitals in the state to try to encourage them and to try to look at the spacing in the emergency. Very crucial. This next slide, please. Next slide. Okay, thank you very much. So we'll quickly look at the engineering controls. Now, these engineering controls are very crucial because, again, when you don't have these controls in place and you have to rely on PPE, it's a very challenging situation. There was a particular, so we're looking at the basic infrastructure. How do you have separate entries and exit points? You have multiple entry and exit points so that you can have an entry point for suspected cases. You know, do you have a holding area? All these are things that you may have to develop, you know, and it's even if you do not have even if you do not have them, yeah, some of them are very easy to build, they are very easy to improvise. It's very important to have this. Adequate ventilation is very crucial when we're talking about severe acute respiratory illness like SARS-CoV-2. One of the hospitals that had quite a massive outbreak, by the time we went to investigate, we discovered that, I mean, one of the things that we thought was, when we did a root cause analysis, was that the hospital was one giant cooling box because it was the same ventilation system that ran through the entire hospital. So when you have a suspected case in any part of the hospital, boom, the virus travels through and then goes everywhere in the system. So and then it becomes really challenging, you know, when you're trying to take care of suspected cases in that kind of environment. Spatial separation of 1 meter between patients is very crucial, you know, because some of these patients, again, when we investigate, when we have these outbreaks, we discovered that some of the patients came in with other sicknesses. Some of them came in with diabetes, and then in the process of admission, developed signs and symptoms of COVID. And like Professor Tobias just said, some of them may actually be asymptomatic for a long time, up to 2 weeks. And so we should have that thinking in our mind that even though this patient may present with what looks like, let's say, fracture, it may also have COVID, co-infection. And then because we're getting to that level of sustained community transmission, and so we must maintain proper distancing between our patients at the facility. Sometimes some of the facilities we have been to, we have to take out some beds, we have to create enough space. You know, clear and adequate identifiers are very crucial at every point. You must have posters everywhere. Sorry, I'm not done with the slide. Sorry, you must have very crucial identifiers. If you have an holding area, everybody must know. We've had cases of healthcare workers walking unsuspectedly into very contaminated areas. So it's very important. Your water and hygiene sanitation structure is very important. Care of food, medical waste management, all these things are very crucial in your engineering and environmental controls to facilitate infection prevention and control in our facilities. Next slide, please. Okay, so this is an example. This came from WHO on building of a SARI treatment center. And again, we can see that very crucial that the ventilation is very, very important too. I mean, you're looking at either you're having airflow of 160 liters per second, or you have at least 12 air exchanges in an hour. So, you know, some of the places we've gone to, we have to create extra outlets, you know, for air, you know, so that, you know, here you can create them in the roof, you can create them breaking walls and all that, or building large windows. All these are very crucial to help in. Next slide, please. Especially when you're trying to use natural ventilation. If you're trying to use a hybrid system, that's natural plus mechanical ventilation, we're talking about usage of wind towers and air extractors. These are things we have to start factoring into the design and the redesigning of our facilities. I don't know what Professor Tobias thinks, but I may be worried that COVID may be with us for a while. It looks like something that will stay for some time. Like HIV has been around since 1981, and we still have it now. So we really may have to rethink a lot of the things we are doing and look at how we can improve our practice. Next slide, please. For example, this was one of our isolation facilities that we went to inspect. And, you know, so we had to make sure that these windows were always open to ensure that there is a lot of natural ventilation. We asked for the extractors, like the extractor there at the right-hand corner. We asked that it put down, put more extractors to help to circulate, to create air exchanges. We should remember, because most of our facilities, because we're in the tropics, we use air conditioners, and air conditioners, they are not very good with COVID, because what the air conditioning does is to recirculate the air in the room, you know, and so if you have, it changes the dynamics of the transmission. You know, it changes the dynamics, and then it makes it a bit more infectious when you have that. So you have to create these ad hoc systems, having extractors, putting your HEPA filters, and creating as much as possible natural ventilation, to help to exchange the air and to allow airflow rather than just air recirculation. Next slide, please. So next slide, we move on now to talk about our favorite word, PPE. That's what everybody wants to hear, PPE, when it comes to infection prevention and control. And for PPE, it's very important to note that PPE must be worn on a risk assessment basis. We call it point of care risk assessment program. If you don't wear PPE that you don't need, because number one, it's a waste of the PPE. Number two, it may give you a sense of false confidence, and then you don't take adequate precautions, and then you may end up getting infected. So, we've had very ridiculous examples sometimes, which we've seen because of the fear and the panic. I recall a patient that was brought into the isolation center. It was brought in an ambulance. The driver of the ambulance was on PPE. The paramedic bringing the patient was on PPE. The patient himself was on PPE, full Tyvek PPE, what we call the Ebola. And you wonder what's going on here, So what was the risk? So it's important. What am I going to do for the patient? What is the risk to the procedure that I am doing? What level of PPE do I need to wear? All these are questions that we have to ask at every point we are putting on PPE. We have to have that sense of responsibility. We know that there's a global reduction in the supplies of PPE because we are having a pandemic. We've never seen this in modern times. And so we have to have that sense of responsibility anytime we are using any of those materials. Don't just use face masks and throw them away because you can. Because one day those face masks will finish, and then what happens? PPE must be worn properly. If you don't wear them properly, then there's no point. We see a lot of people don't wear PPEs properly, and I would just quickly like to demonstrate that with, for example, a face mask. We see a lot of people wearing face masks with the white part outside. They tell you, oh, they are not the ones that are sick. When you're the one that is sick, they say, when you wear that, that was just a post that went just so wrong. There's only one way to wear a face mask. And that way is that the lighter color is always inside, whether it is white, whether it's light blue, you always put that color inside because that's the one that is a bit absorbent for your own secretions. And the one that is brightly colored, green in this case, is the one that is on the outside. And then it's always this way. And then this is how you put it on. And then you put it still, and then there, like that. And then this is how to wear a face mask. But then we see people doing this. This is wrong. You don't do that because when you do that, what you've just done is to transmit all the organisms to your hands. And then all the organisms you're trying to prevent from coming inside, you transmitted them to your hands and then to your jaw, and it becomes a challenge. And then we see people doing this, and then we see people doing this. I mean, it's just all wrong. So PPE must be worn properly. And when you're going to remove PPE, it must be removed safely. A lot of studies have shown that a lot of people actually get infected from the process of removal of PPE. So it's very important for us to know how to remove PPE properly. And after removing, dispose safely. And your 5 moments of hand hygiene is the basis of any PPE you are wearing. If you're doing your PPE without hand hygiene, you're not doing much. Next slide. Thank you very much. Now, I mean, this went viral after the death of our former chief of staff, may so rest in peace. And this video went viral of a particular man who supposedly took part in a burial, and then he just threw away his PPE right there on the road. So this is what happens when there is no training. And that is why training is the basis of anything in IPC. The worst thing you can do to any healthcare worker is to hand them PPEs without any training. Because what you're doing is giving them a false sense of confidence, and then you have disasters like this. I mean, this man just went, remove this PPE without following any due process. There was no hand hygiene, there was nothing. And then he left it there and drove away. And another person came and picked it up, and then it becomes a serious issue. So the issue of training can never be overemphasized when it comes to IPC. Those are the administrative controls that you need to put in place to ensure that there's a bit of protection in the healthcare setting. Next slide, please. We have to remember that we have to minimize the need for PPE, and that's why we're doing teleconferencing. Okay, we should looking at teleconferencing for our patients. Patients shouldn't come out to the hospital except in emergencies. This is a time to explore those options. Do we look at barriers? Which barriers can I put in? Can I put a distance between me and the patient? Do I need to use PPE? Anything that can be done to reduce the use of PPE should be pursued with a lot of zeal and zest, because the challenge is that PPEs are not inexhaustible. And we're having a global demand for PPEs the supply is limited, and so the PPE is scarce. So PPEs must be used appropriately, okay? And then, you know, I mean, the work of the managers of these facilities is to make sure that your staff have enough supply. But the challenge that a lot of facilities have been having is that even when they have a lot of supply and it is misused, then it creates a challenge. And so there must be training, and there must be a bit of discipline and responsibility with the use of PPEs so as to ensure that the PPE is available when it is needed. So don't wear PPE when you don't need it. Wear it when it is needed and use it for as long as you can before disposing it. All over the world now, people are thinking of reusing N95s because there's a global shortage. And so they are looking at steam sterilization, using hydrogen peroxide, using ultraviolet gamma irradiation, and all sorts of means, because the supply is limited, and so they are looking at how you can reuse these things. Next slide, please. So let's quickly look at the PPE that is needed for different things that we are doing. Remember that based on the science of transmission, the coronavirus is basically, like Professor Tobias said again, is transmitted through, is a droplet infection. So you're wearing about your nose and your mouth, and then probably your eyes too. You know, but majorly the nose. It's very important, you know, to protect that. You know, and so whatever you're doing, even when you're trying these patients, you, of course, at the end of PPE, you must do your hand hygiene, your fine hygiene before touching the patient, after the patient, before going from a clean surface and all that. It's very, very important, you know. But with triage, for example, all you need in triage is a medical mask. Once you put on your face mask, you maintain a reasonable distance from the patient. There's a lot that can be done, you know, without you necessarily having to put on any other thing. You see people wearing gloves and using the gloves to touch everything, contaminate everything. So it becomes quite challenging when this is occur. So it's very important that, you know, for triage, you need your mask and your hand hygiene. Or you're collecting specimens, you wear your gown, because sometimes the patient could sneeze or cough, and then you may need to use an N95 because sometimes the aerosols could be generated during that procedure, and then you need eye protection with your goggles. Remember that glasses is not eye protection, it's not the same thing. You know, you need your goggles, you know, that you wear and to protect your eyes. You know, for suspected or confirmed cases, again, you need your gown, you know, and the gown that is needed is not a full Tyvek gown. And then when you're doing aerosol generating procedures, and this is very important, the aerosol generating procedures in COVID-19 are procedures like mechanical intubation, mechanical ventilation intubation, suctioning, nebulizer with high flow oxygen, tracheostomy, colonoscopy, endoscopy. All these are things. If you are not doing these procedures, please, you do not need to use an N95 face mask. And this is very important because there's a global shortage of these things. And so a surgical face mask we do. And then we see all sorts of modifications going on all over the world. Now some people will wear the N95 and they put a surgical face mask over it just to preserve the N95. And then we are reusing N95s. These are things that are totally unheard of a few months ago. You know, so it's very important to have this rational use of PPE, because there's an irrational, injudicious use. And we should remember that these things are not inexhaustible, and they should be properly kept and used when necessary. We are not saying doctors should not be protected. No, we need to protect ourselves, but the protection must be done and properly done. Next slide, please. So, for example, next slide. So this is the CDC, and basically in Nigeria we use the same guidelines. You know, what are the acceptable things? What are the things you need to use? And we can see your face shield or your goggles, not both. I've seen people wearing both. It's either or. You know, some of us prefer the face shield because it doesn't fog easily. And so you can do a lot of procedures. You can do surgeries, you can do your lines, setting lines, central lines, and all that. Doing that, you can use an N95 or IR respirator, okay? And I mean, it's very, your gown, you just need a surgical gown, and you know, and a one pair of gloves. You know, some people double glove, which is fine, and that's all you need. You can use that on your normal clothes. You can wear scrubs if it makes you feel safer. You can do what they call the bed below elbows technique, so that you don't have any cloth interfering with your, you know, as a point possible contamination. You know, Professor Tobias said there's a lot of research going on into fomites. Whether fomites can really aid transmission of the virus is a bit unclear. But if you're worried, just use your clothes when you're dealing, use your scrubs when you're dealing with some of these patients. So this is all you need. It's interesting when you look at this slide that all of a sudden there was an acceptable alternative use. And they were saying, okay, you can use your face mask. If you have your N95, you can use your face mask. Now, that happened when even the US was running out of N95s. And all of a sudden they say, okay, fine, if you're not doing an aerosol generating procedure, we can use a face mask. And so there's a challenge that if big, huge countries, these countries, they have better systems, they have stockpiles of these PPEs, if they are running out of these things, then we can be very sure that in the nearest future, in the not too distant future, we're going to run out of these PPEs, and we should use them and reserve them when it's absolutely necessary. So you don't need a full Ebola suit to take care of COVID patients, because I mean, Ebola has a very strong contact feature. So if Ebola lands on your hand, and it can penetrate through a small hole you cannot see, and then boom, you can develop the virus. But for COVID, if COVID lands on your hand, it will infect you until you bring that hand to your face, either your eyes or your nose, or somehow maybe your mouth. And so if it lands on your hand, it stays there, and then you can wash it away. So you really don't need the full suit. This contact is just okay. It's just enough. Next slide. So next slide, please. So this is me. I sometimes I take part in case management, taking care of patients. This picture was taken at the Lagos University Teaching Hospital, and that's me working actually. And that's all I have. I have my own clothes with me, my street clothes, and then the gown, the gloves. I just wear a pair of boots because I love the boots. They're fine. And then I use the surgical mask here because I wasn't doing any aerosol generating procedure, and then the goggles. And that's all. That's all you need to use. That's all you need to use in taking care of COVID patients. However, there's a lot of fear, and people think that the more the PPE, the better protected you are, which is not necessarily the same thing. Next slide. We also could use that. That's also be there in the background. Wearing the full Tyvek suit, what we call the Ebola PPE. And here I was supervising, and this was training. Sometimes we have to do hands-on training, follow people into their isolation and watch them. They give them some confidence, because you're not just speaking theory. That you're not somebody who leads from behind. You lead from the front, follow them into the field, and that's me there. And that's the full Tyvek suit. Now I don't do this, but that was always available. So that's an alternative PPE that we can use if taking care of those patients, but it's not necessary. The Tyvek PPE is more difficult to remove. It's more difficult to remove, and you could have mistakes when you're doing that. So, but that's also something that is widely used in Nigeria for taking care of COVID patients. Next slide. Okay, so we'll quickly talk about screen, isolate, and notify just about 2 or 3 more slides. Now, many of us are not interested in taking care of COVID patients, especially in the private setting. We say, look, I don't want to work in the isolation facility. But then a lot of patients will still come to you. Like I said, most of the healthcare worker infections we've had in Lagos has been from the private health facilities. So you have to have a system for screening, isolating the patient, and notifying the authorities. We call it the SIN approach. Next slide, please. Next slide. So every facility must have a screening point. We actually advise you to have a screening point outside the hospital, because by the time these patients have gotten into the hospital, then it's almost getting too late. So you have a screening point outside the hospital, and now your screening point, some people screen patients while they are in the cars. Sometimes do that, or whatever vehicle they convey to the hospital. Some have tents, some have carports. All these are modifications you can do to have a screening point outside the hospital. Remember that your screening point must not be congested, because if you do that and the screening point is congested, then that point becomes a focus of dissemination of the infection, and then you could actually infect all the patients. So you must have kind of forms or kind of questionnaire that you fill for the patient, looking at the common symptoms of COVID, like fever, dry cough, difficulty in breathing, anosmia or dysgeusia or specific. So we tell people, if you wake up in the morning, you spray your perfume and you cannot smell it, man, just walk into the isolation facility. It's very likely you have COVID, because there are not many things that cause that. Now, unlike the other symptoms, which could be not specific, gastrointestinal symptoms, nausea, diarrhea, vomiting, diarrhea, very common from the experience we've had in Lagos. And also, there are new symptoms, and that's a challenge with this disease. Now we are adding new symptoms like confusion. We are looking at neurological symptoms like stroke, like Professor Tobias said. So, and that's the challenge. And this is why I tell people when I'm training, look, we give you this training, but eventually it's inevitable. A patient will get in that you're not aware of. The patient has COVID, but the patient is inside the facility. But what we do is, when you do all these processes, it will reduce the rate of that happening and to help you. So it's very important to know that traveling history is no longer important. Now we have community transmission. So when you still ask, have you traveled? No, Now people are worried. You know, I mean, people in other states in the country are asking, you go to Bauchi, they're asking, have you traveled to Lagos? Because Lagos is now the epicenter. So if you are in Lagos or Kano or Abuja or many of the state transmission, so history of travel is no longer important. So have a screening point preferably outside the hospital so that you can immediately make your decision from there. You know, let's move to the next slide, please. Okay, so after you screen, then you isolate. Now, when you are isolating your patients, you should have an holding area. The holding area, it's better for the holding area to be separate from the rest of the hospital. So usually, again, our hospitals were not designed for these purposes. So we have to make a lot of modifications. Sometimes you build a fence, sometimes you just build an adjacent building, sometimes you use maybe the security post or something, just a place where you can keep the patient safely while awaiting evacuation of that patient to the appropriate isolation facilities. So it should have a separate entry and exit. It should have a separate ventilation system from the rest of the hospital when you're having a holding area. And then when you're having a holding area, it's very important to educate the staff that a patient is being held here so that patient staff does not wander into the place. So for any patient that you have a suspicion of that this may be COVID, it's very important that you are able to isolate them, provide some level of care for them. And that's been the challenge because some people just abandon these patients to run away, and then some of these patients need oxygen, they don't get it. They need basic care, they need you to set a line. So that's why every facility should have a reasonable stock of PPE, maybe 10 or something, so that in case you have this your patients, you have been with them for several years, they are now coming in with features of COVID, you don't abandon them in their time of need. And that's why we are doing this training, to give everybody that level of confidence to be able to interact and deal with this virus. So you isolate the patient. Next slide, please. And then you notify the authorities. So it's very important that every facility you have an IPC focal person. Your IPC focal person is going to be the one that is going to be in charge of this thing. It's going to be the liaison between your facility and the state, you know, and the state government. So for Lagos State, for example, you can call the 08,000 Corona. We interact with the NCDC too, the federal, everybody works together, you know. So notify the state response team, notify the NCDC. What we know is that sometimes because of the challenges with logistics, there could be a significant delay between the time you call and the time there's a response before the authorities come into your hospital. So it's very important to note that there could be that delay and so be able to provide a level of care for the patient while that patient is awaiting evacuation. Also remember that immediately the patient is moved, the area should be cleaned with 0.5% chlorine solution before the next patient is moved in, or just clean it immediately so if there's any trace of the virus that is there, then you clear it. Next slide. So remember, please, the SIN approach again, please don't turn patients away. All patients must be triaged. We should remember that the private facilities, especially, they form an entire essential bedrock of the health system in most states, especially in Lagos states. And I mean, these are the places where it's the first port of call for a lot of people. So please, this is not the time to abandon these people in their time of need. These patients must not be turned away. All patients must be triaged. Some level of care should be given, and then the authorities notified and the patients evacuated. Please, you must have a high index of suspicion for COVID-19. The presentation is myriad, is protean. You can't really say it's this or that. We are developing new symptoms are coming out every day. So you must be able to have your high index of suspicion and have a low threshold. And that is why you must be able to provide some level of care while the patient is awaiting evacuation. And please, it's important, please protect yourself, protect your hospital, protect your colleagues, protect your patients, and protect your community. It's very important to note that for every healthcare worker that is taken out of circulation, it's a big hit on the system. We don't have enough doctors in Nigeria. We know that. A lot of our doctors have gone away for various reasons. Many of them have traveled, they have left the country. And now we are in extremis already. So now when we already have this cricket health system, and then you are now taking out these very important doctors and nurses. For every surgeon you take out, that's a lot of people that cannot access surgical care. For every physician you take out, that's a lot of people. For every nurse you take out, that's a lot of people that cannot access this very specialized care. So it's very important for us to protect ourselves, protect our colleagues, and protect other patients, and we should protect the rest of the community from this scourge. Next slide, please. Okay, so in conclusion, IPC is a way of life. IPC is not just for COVID. IPC is something that we should be part and parcel of our practices in our hospitals. It's very crucial for us to realize this. And, you know, the vagaries of time will not allow us to go in depth. These are the hours and hours of lectures we have on IPC normally, but very important to understand that this is basically a droplet infection. It could become an airborne infection under opportunistic circumstances. And we should note that all we need to be very wary of is that, especially our nose, our mouth, our eyes, and also our heads, because our hands go everywhere. The surgical gown is enough. We don't need to full Ebola type of PPE. We should not be afraid. I work in the front line with these patients. I've treated patients, I've handled cops, I've done everything in this response. And I mean, we all have to conquer our fear. And we understand people are scared. You're scared you may be infected. You're scared you don't want to infect your family. These are real fears. And these are things that we try to handle by doing these trainings and giving everybody that confidence. COVID is here. We thought it wouldn't come, but it has come. It was there in China. We were watching it on the news or watching on CNN, and we thought, oh, the sun would kill it. Our immunity is stronger. We have suffered enough. This thing cannot come, but it is here, and people are dying, and they need our help. This is not the time for us to run away. We're having hospitals shutting down. No, please. Every hand has to be on deck. Remember that your years of experience cannot be removed. We cannot bring in security men to do this job. Bankers will not do it. Politicians will not do it. So we have to implement these practices to protect ourselves from the ravages of the coronavirus and offer the care that we have spent our lives training for. Thank you very much.
All right, thank you, Dr. Opawoye, for your session. And before I talk about the questions, yes, PharmAccess will be organizing many more such webinars, because I know you mentioned during your presentation. So we have a number of questions, but for time's sake, we'll be taking only 3 before I hand over to Dr. Idowu to give a closing remark and then come back to close this meeting. So the first question is on the government's, what the government has in stock for private facilities, since a number of these cases seem to come from the private facilities. Is there any plan for the health workers in private facilities?
Yeah. Well, so what I know is that the government is rolling out trainings, and this training, for example, was done in conjunction with a pharma, which is an arm of the government that does facility assessment and monitoring of these private hospitals. So pharma has a lot more in plan. Maybe Dr. Idowu would talk more about that in terms of training, which is very crucial, because again, when you talk about the first thing is, supply everybody with PPEs, give everybody suits, give everybody face masks, N95s. But that is not what we're talking about. That is important. The training is very crucial. So there's a lot of training that is being planned. There may be also be moves to also have a wider distribution of PPEs. I wouldn't be able to answer that, but the training is what the government is really working on, because that's the most important component of IPC. And there's a lot of plans on that.
All right, thank you. So there's another question here, and this person wants to know your take on the use of face masks made with fabrics and this putting off lighter tests, and how they offer any form of protection. Do you think that these tests are acceptable, and what's your take on the use of this sort of masks?
Okay, yeah, well, so the challenge with masks is that, we all know that the surgical mask is a very specially made fabric, actually, because when you try to use it, I'm trying to look for my mask now. I don't know if I can find it. Yes, it's just dropped here now, but basically you can't, if you put it on your mask and you try to blow air, air won't get out of it, because it has a filter in between, but you can breathe in, but you cannot breathe out. it's very difficult to find materials, cloth materials that could do that. Now, the cloth mask does not give you the same level of protection as a surgical face mask does. But the cloth mask is better than nothing. It's better than carry your nose about. And the advantage is that you don't want the surgical, you want to reserve the surgical face mask for the healthcare worker. And that's why CDC, WHO says, please, if you want to, you must use a face mask as a normal person. You're not taking care of sick patients. You're not working in the hospital. Use a cloth mask. So the cloth mask is not as effective. Because people have asked me, oh, should we use Ankara or lace or DeGeorge? Or should we use Ashoke? I said, well, just use whatever makes it easy to breathe. So it's better than nothing, but it's not as effective as a surgical face mask. But please, let us reserve the surgical face mask for our healthcare workers so that they will be better protected.
Thank you. So one last question. How do you define when PPE is absolutely necessary in our peculiar health system vis-a-vis this community transmission?
Yeah, well, so we need a bit of data because so what happens is that the epidemic is always changing, right? There was a time when all we were worried about was watching the borders, the land borders, the sea borders, the airports. It was the foreigners that were bringing it. Later, it was like a disease of the elite. For Lagos, for example, a lot of the cases were Lekki, Itiosa, Ikoyi. Now we're having cases everywhere. Alimosho, Amuwo, Dofe, Kusofe, all the local governments, more or less, have been affected. So the changing dynamics of the disease dictates the response we'll have. Right now in the UK, for every patient they see, because the UK, they have almost 200,000 cases, they wear PPE for them, meaning your face mask and your goggles, and then of course your hand hygiene or your gloves. So I don't know if we're at that level yet, where we are going to say every patient must be on PPE for that. But I think that in our setting, the list for everybody that is in the triage, at least I think it's good you have a face mask. And if you use your face masks properly, you can use them for prolonged hours so that there's a rational use still. So you have your face mask, and then when you interact with the patient, you keep your distance, and then you talk to the patient, then you know whether you can move closer or you have to step back. For example, the patient comes into the ER, and then, or your screening area, you have your face mask as you go in, and then you get that patient is coughing, patient is obviously breathless, oh, this patient is a high-risk patient, and then you move back, and then you can get your other PPEs. And then remember, we are looking at reusing Googles, reusing N95s, so all these things will make it easier to optimize the availability. So for our setting, I think at least you should have a face mask when you are going to attend to patients that you don't know. And you remember that patients are also lying now. So when you're not sure, I think just better to be safe, just use a face mask at least.
Right, thank you, Dr. Opawoye. So now I would hand over to Dr. Idowu to give us our closing remark and then come back to close this meeting.
Coronavirus poses an extraordinary challenge in so many ways that we have never seen before. So even as an organization, we're not going to relent in bringing to you trainings, as Dr. Opawoye has said. We're going to continue to train and retrain so that we're on top of our IPC and we have enough knowledge. So we are confident and not afraid. Thank you very much.
We had a number of questions, but because of time, we couldn't take them. So you will get answers to all the questions along with the resources for this presentation. So thank you everyone again for joining. Please do keep safe, and hopefully we'll reconnect again soon for more of such trainings. Thank you and enjoy the rest of your day. Bye-bye.
Thank you very much. Thank you. Bye-bye.